Hey, everybody. Uh, I was all planning on a different topic today, but then something happened a couple weeks ago, and it kind of turned me on to this. So I'm kind of gonna cover this instead. And plus, the one thing that we all, at least all of us microbiology people like to do is sit around and talk around cool bugs. So, we'll go through a few cool cases here. Um, Working in a micro lab. So, these are bugs here that we all have concerns about when we're handling patient specimens. Starting with HIV decades ago, we got into the whole concept of universal precautions and minimizing the risk of exposure to these specimens, organisms that can be found in patient specimens. And all of healthcare is built around that now. So we're all kind of used to that. And I can't fuss about us in the laboratory all that much with regards to this, because this is the way we handle the specimen. This is Paige sitting there working with the sputum specimen. We're in a biological safety cabinet. We're really not going to be exposed to anything that could be in that specimen. To be honest with you, I'd much rather be doing that than going through what physicians and nurses and respiratory therapists and other healthcare professionals have to do when you're actually working with the patient. We deal with these specimens under very controlled, contained situations, as opposed to a patient who's coughing up who knows what. So I'm not going to talk about that kind of stuff today. But I want to talk about some of these bugs. These are ones that are special concerns in culture, because we're more concerned, I shouldn't say more concerned, but we have a big concern about spreading these organisms to healthcare workers when they're in culture. And in particularly today, the ones I really want to talk about are these guys right here. Because these are ones that are particularly infectious out of a culture. What I mean by that is that, especially you look at things like Brucella and Francisella, for the most part, maybe not so much Neisseria meningitidis, we're not that concerned or not concerned at all about a patient spreading that disease to a physician or a nurse or anybody else in the healthcare setting. They're not really infection control risk in the hospital, but they're much, much more infectious off a plate. So when we have it in culture, in the micro lab, that's when there's a great concern of spread to one of our laboratory staff. Now, there are certain things we can do to minimize this, certain things we do to hold back on this risk. And this is the biological safety cabinet. We have several of these in micro. We will do all the work on a culture inside one of these cabinets. If it's a known highly infectious organism, if it's acid fast bacilli, if it's a mold, all of that, all manipulation takes place inside one of these safety cabinets. And you can see the diagram here. It's the airflow, it's a laminar flow hood. The air comes in, it goes through a HEPA filter, it's funneled down through these channels back up into more HEPA filters. So anything that gets released inside this cabinet while we're working with the culture doesn't come out this opening and infect the person. It's going to be filtered out through these HEPA filters and then vented out into the room, nice and clean, fresh air. But when we read plates, we don't use that. Reading plates, looking at cultures, that's going to be done just like Yaikse here is doing. Typically on the open bench, we don't wear gloves. Some techs do wear gloves, but basically no, there's no respiratory protection there. Depending on what this bug is here that she's holding, you're a foot away from your face. There could be an issue with that. So how dangerous is it? For most bugs, it's not dangerous to do it this way. I'm not really worried about Staph aureus jumping off that plate and getting onto one of our staff. But for some bugs, we are. So let me tell you what happened 2 weeks ago. All right. This is a patient who went to one of our immediate care centers. She had a small abscess on her arm. They collected a specimen from that abscess and sent it to us for a wound culture. The very next day, she's feeling worse. She ends up in one of our hospitals with all of these really systemic constitutional type symptoms, much more than just an abscess on her arm. They actually collected spinal fluid that we cultured. We ran the CSF pathogen panel on it. All of that's totally negative. So none of the common causes of meningitis here. They didn't do a blood culture. I would kind of look at it and say, I think this patient deserves a blood culture, but they didn't do one because of the national bottle shortage. We have these very tight restrictions on that. So no blood culture was sent. But luckily, we had that wound culture. It didn't grow at all for 2 days. On the third growth, third day, we see growth on chocolate agar only. When we see growth on chocolate agar, but not on blood agar, what comes to mind is Haemophilus. Okay, either Haemophilus or Neisseria gonorrhea. Okay, could have been either one of them in this situation. That's what we're kind of thinking. So we put it on the MALDI to find out what it is, but MALDI had no idea and gave no identification. We subcultured it. We tested again 2 days later. Still no identification. So MALDI was unable to identify this organism. That's when somebody decided to gram stain it. And what we saw was very similar to this here on the right side. You can look at this, and those are gram-negative rods, but they're very, very tiny. They're almost completely round. Shoot, if you made that purple, you'd be thinking you had gram-positive cocci. But they're very, very tiny little gram-negative rods. And just to kind of show you, this over here would be what Haemophilus would look like. Again, they're short rods, but they're definite rods. So as soon as we see this, look, these very tiny gram-negative rods growing on chocolate agar, but not on blood agar, the first thing that comes to our mind is a potential select agent and probably Francisella tularensis. So when we get a bug like this, there's certain testing that we're allowed to do. We are not allowed to actually make the final identification of these organisms, but what we can do is we can do some rapid tests, some quick tests, some easy tests, and try to rule out Francisella. So we kind of go down this way. You can run this little flow chart. This is a document that comes from the American Public Health Laboratories. And as we go down this, we say, okay, we're looking at this possibly being Francisella. We can go to the guidelines for Francisella and say, does it meet all of these criteria? Yes, it does. That looks like it. So I can do a few more things. And then we get to the point where we can't rule out Francisella. I think that's what this is, but I can't say for sure. MALDI's not going to tell me. I don't have a way to definitively identify it. I'm not supposed to definitively identify it. Instead, I send it to our state laboratory and they do it. So when it comes to select agents, potential bioterrorism agents, highly infectious agents, we have around the country the Laboratory Response Network. And I'm not going to go too much into this because it's not really my intent to be talking about how we deal with select agents. But just to kind of give you the background of the way we do it this way, almost all hospital laboratories are going to be called sentinel laboratories. We're going to be the first people to recognize that there is a potential bioterrorism outbreak. And if you can read this kind of fuzzy wording here, it says recognize, rule out, and refer. What that means is we can say, look, I think this might be a Francisella or Brucella or an anthrax or something else. I need to refer it upstairs to see. So Norton Healthcare Microbiology Laboratory, we are a sentinel laboratory. Our reference laboratory for this would be the Kentucky State Public Health Laboratory. And then the national laboratory up at the top is going to be the CDC. So in this particular case, we have this bug, we're working it up. We've been working it up for like 3 days now that it's been growing, and we haven't been able to figure out what it is. But we decide we think this might be a Francisella. That gets referred, we send that to Frankfurt. And Frankfurt does some presumptive testing and says, yes, we agree, this looks like a Francisella species. We presumptively identify it as a Francisella species. And then from there, it goes to the national laboratory, to CDC. I believe Francisella actually goes to the lab in Fort Collins, Colorado. And they will do some fancier testing, some PCR, some sequencing, and they will be able to identify it more definitively as Francisella tularensis, and even down to the subspecies level. So that's what happened with this particular case. And sure enough, it comes back. It hasn't officially, believe it or not, it hasn't officially come back from the CDC yet. We still say that this is Francisella, and the state agrees with us. CDC is being really slow about this one. But yes, it's Francisella. So once we know we have ourselves a Francisella, then we have to start looking at the possibility of employee exposures, because this is a bug that can be quite dangerous in culture, easily infect people who are working it up if it's worked up outside of containment, outside of a biological safety cabinet. So this is the fact sheet from the CDC, and you can kind of see exactly what you do with your employees depends upon the nature of the exposure and how concerned employees are about their own risk. But management options, a fever watch. So you basically take your temperature twice a day for 2 weeks. That's the range of the incubation period. I'm happy to say we just finished our fever watch yesterday, and as far as I know, all our people are still cool. So we managed to get through that. And if necessary, we can do prophylactic antibiotics. If we had somebody who really was a fairly heavy exposure to it, they're quite concerned about their risk here, then doxycycline or ciprofloxacin can be used. So exposure is going to happen. You need to be able to follow up on that exposure to make sure nobody comes down with it. This is our Francisella timeline. This is when 2009 is when I got to Norton. 2024, here is the case we just had. And what you'll see here is we pretty regularly had cases of tularemia all of this time in here. And I want to tell you about a few of those because it's just fun to talk about cool cases. The actual first case that we got, this guy right down here on the end, was a farmer who had gotten bitten by a lot of tick bites on his legs, and ended up getting a cellulitis running up the side of his leg. An unusual presentation for Francisella, but that's what we were able to grow out of it. There are a couple more that were interesting. One, the risk factors for tularemia, contact with infected animals, tick bites or other arthropod bites, breathing in aerosols from infected animals. Those are your typical risk factors. But a couple that were interesting, we had one woman, she was like 80 years old. She was out trimming the hedges in her backyard and cut her finger. I don't know if she cut her finger on a bush or whether she cut her finger on the clippers. But she was dead 3 days later from overwhelming tularemia from that cut. We had another case. I called up the infectious disease doc and said, we think this is tularemia. We're sending it off to the state for confirmation. And he said, no, this is not tularemia. This is a guy, an older man who sits in his basement in his recliner and watches TV all day. He doesn't go outside. He has no risk factors for tularemia. And lo and behold, he did have tularemia. So there's some cool cases there. But what I want to point out with this picture here is what happened in 2016, where we all of a sudden stopped getting cases of tularemia. All of a sudden, nothing. And the only thing that I can come up with as far as why we were not getting tularemia cases is 2016 is when we got MALDI for identification. Which means, when we get a bug growing on a plate, we're going to put it on the MALDI. And if it doesn't work, we're going to MALDI it again. And then maybe we'll MALDI it a third time. It used to be when we got a bug growing on a plate, we'd gram stain it. And the first thing that we would notice is that these are teeny tiny little gram-negative rods. We don't do that gram staining off that plate very much anymore. We wait for Maldi to give its shot. But Francisella, Brucella, anthrax, plague, burkholderia, malii, pseudomalii are not available in the database for either of the two commonly used Maldies that are out there. You're not going to identify it. It's not in the database. Maldi doesn't know Francisella exists. That to me is something I've complained about and complained about and complained about, because we ended up working with this bug for 3 days longer on the open bench, more than we needed to, because we were trying to get Maldi to work. You know, if Maldi had the bug in the database, we could have stopped on day one and said, okay, we're going to seal this up. We're only going to handle it inside a biological safety cabinet. But not having it in the database is a big risk factor for continued workup on the open bench. So I kind of look at this and say, we stopped identifying because it's not in the database. And somehow, what did we do? Did we falsely identify it as something else? Did we just give up on it? What? I don't know. But I think that's a contributing factor. Now, I'm very happy about this because, 2 weeks ago when I called up Bruker, the company that makes our Maldi, and complained about it, they said, well, look, we got this database now. You can buy a new library that contains these organisms. This library used to be so expensive. It costs thousands upon thousands of dollars for you to buy a database with just these bugs in it. And I said, well, forget it. We can't do that. But they've decided it's very important for laboratories to be able to identify these B. Maldi, so they've actually dropped the price down to $200. And I'm like, okay, most of our employees, I'd pay $200 not to expose them to a deadly agent. So we're going to look into this. It does require a certificate issued by the German government because this is a German company. Interesting from that too, we have Adolf Hitler to thank for that. That was a rule that was placed on the German government back after World War II, that they had to keep track of this kind of thing. So, but we will be able to identify, if we get this, we'll be able to at least have Maldi say it's Francisella, and that will save us a little bit of pain. Okay, let me talk about another case. This one was from last year, I think. Young male patient had recently come from Central America. He shows up at one of our emergency departments with scrotal pain. They took a blood culture, which I think was interesting because if this guy had come in 2 weeks ago in the middle of this blood culture bottle shortage, he wouldn't have gotten the blood culture. Sorry, scrotal pain was not on the list for what gets you a blood culture, but he got one last year. He was given a dose of ceftriaxone and he was sent home. And that blood culture was important because what happened is 4 days of growth. It took a long time for anything to grow. And once we streaked it out onto the plate, it took a long time to grow on the plate. But it grew on blood agar and chocolate agar. Same story here. Nothing identified by Maldi, nothing identified by Maldi when we did it again. Did a gram stain, teeny tiny little gram-negative bacilli. So we go down the same flow chart. We look at that and we're thinking in our head, this is going to be one of those select agents. It's growing on sheep blood agar, so I don't think it's Francisella. And we go down the list, we say, okay, this comes out looking like it's a Brucella species. Go down the rule out algorithm, and it's yes, 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 right down the chart. And now we have a potential Brucella species. This is one we're really very concerned about, and I'll show you why in a few minutes here. This goes to the state. The state identifies it as a Brucella melitensis. That is a species of Brucella that typically hangs around goats and sheep. And when this guy came back into the hospital to be treated for brucellosis, he did give a little bit more history, which said that before he left his home country in Central America, he had made homemade goat cheese and had consumed quite a bit of homemade goat cheese. That's a ingestion of the organism is a common means of transmission of brucellosis. I didn't say much about Francisella as a disease, but let me point out with brucellosis. Here are some of the common symptoms over here. You see these just very general, non-specific symptoms that you can get. I mean, I've got like 4 or 5 of these right now. I'm not too concerned that I've got brucellosis. So it's a very difficult diagnosis to make. And what makes it even more difficult is that sometimes it's very acute, sometimes it's asymptomatic, and it can be everywhere in between. So you can have people who can have low levels of these symptoms and go on for months and months and months and not really realize that they have anything infectious wrong. So in this case, that may have been what happened in this case, because then you look over here, these complications, and lo and behold, epididymo-orchitis is a fairly common complication of brucellosis. This guy had not come in with any of these common symptoms at all, had not recognized these at all, but came in when one of the complications showed up. So all of these are potential complications of brucellosis. So it can be a very difficult disease. It's not one of those diseases that jumps to the top of a physician's head when a patient comes in with these common symptoms over here. There have been a few times when physicians have called me up and said, I think this patient may have brucellosis. So every now and then someone will think about it, but it's certainly not one of the common things. And I do have to tell you about it. This is our second case of brucellosis since I've been here. The other one was kind of cool too. This guy, a gentleman who had a wound on his leg. It was like on his calf muscle. He had a wound there. And he went to another hospital, not a Norton facility, somewhere else in town, and they had cultured it and grew MRSA. Makes perfectly good sense what they grew, MRSA. So he gets put on treatment for MRSA, oral treatment. He goes home and he comes back 2 weeks later to one of our emergency departments. This wound is not getting any better. And we grow MRSA and Brucella suis. Suis commonly hangs around pigs. And the only thing I could think of from looking at his chart was that in the 2 weeks between going to one hospital and then coming to one of our hospitals, he had gone to the state fair. And I'm like, man, did he walk around with an open wound on his leg through the pig barn? And if so, is Brucella suis causing the infection, making it worse, just sitting there and not doing anything? It was really MRSA all along. I don't know, but really kind of cool situation. Here's why we worry about brucellosis. Study came out, I don't have this reference will be a little bit later, but microbiology laboratory staff are 8,000 times more likely to acquire brucellosis than a member of the general public. Brucellosis is a problem. Despite being a rare disease, it is one of the most common causes of at least bacterial laboratory acquired infections. So you kind of look at it and say it's almost to the point where when a Brucella culture shows up in a laboratory, someone's going to get it. You know, there's a high risk of someone coming down with brucellosis. So it's taken it's quite a bit more seriously than some of the other bugs that we have talked about. So here's the recommendations from CDC as far as post-exposure prophylaxis and any follow-up or monitoring. This is basically very simple. A person who manipulated a culture inside a safety cabinet. Everything's good in there. Then we come to this page. Somebody who, here we go. Everyone in the lab at a distance of greater than 5 feet from someone manipulating a culture on the open bench. So if one person opens up a culture plate on the open bench, everybody in that room is considered to have been exposed. They should get symptom watch for 24 weeks and sequential serological testing. We've been through that twice. Okay. That's everybody in the lab. And I'll tell you, this last case, one of the people who happened to be working up in the front part of our lab was a high school student. That was her very first day doing an internship with us. And we had to call her parents the next day and say, oh, we just exposed your kid to brucellosis. She did come back. She did finish her internship with us. And here's more stuff, working on the open bench, less than 5 feet from somebody who opened the plate. So we had people who'd worked with the bug, who'd gram-stained the bug, who had moldied the bug. They all get doxycycline and rifampin for 3 weeks, along with the serological monitoring and the symptom watch. So there's a lot of monitoring that has to go along with those. Okay, I got to quicken up here. Select agents, please let us know if you suspect it. I'll give you a good example of this not happening. Our patient who had tularemia had blood cultures sent yesterday. Did any physician call the lab up to say we're sending blood cultures on that woman with tularemia? It might grow tularemia. No. Luckily, I recognize that it was coming anyway. So staff education is very good. Our people in our lab need to know what these bugs look like on the plate, what they look like microscopically, so that as soon as you suspect it, you can close it up and do everything in a biological safety cabinet. Okay, let me give you one more example here. Young male shows up with sore throat, dysuria, penile discharge, and testicular pain. This is not exactly a theme. I didn't mean to do a theme here, but same kind of symptoms. He had had gonorrhea in the past, was empirically treated. But this time, while sitting in the ED, they did the PCR for gonorrhea and chlamydia, and it came back negative. The ED docs didn't believe it. This looked like gonorrhea. He had had gonorrhea in the past. So they didn't really believe that PCR. They sent some additional stuff, including a GC culture, and sent him home on empiric therapy for gonorrhea and chlamydia. But that GC culture grew some colonies that Maldi called Neisseria meningitidis. Gram-stain looked like Neisseria meningitidis. A second Maldi looked like Neisseria meningitidis. We actually took the colony and ran the PCR for gonorrhea on it, and it came back negative for gonorrhea. We did some biochemical tests on it that all agreed that this was Neisseria meningitidis. This was Neisseria meningitidis. And I know this is not, this is not the spinal fluid or the blood isolate, the really classic presentation of Neisseria meningitidis. But believe it or not, if I look back over the past few years, the most common presentation of true Neisseria meningitidis infection that we see most commonly is going to be this basically gonorrhea caused by Neisseria meningitidis, not meningitis or bloodstream infection. Very concerned about this bug. You can see it's 40 times more common in microbiologists. Can you guys hear me?
Yes, we can hear you now.
Okay, I'm getting this thing saying my microphone's gone. Anyway, and when a clinical microbiologist gets an infection with Neisseria meningitidis, the fatality rate is 50%. That would be if it was a bloodstream or spinal fluid infection, 50% mortality. So this is one I really worry about quite a bit. You're really more concerned about these blood and spinal fluid isolates because those are the ones that are proving themselves to have the virulence factors needed to cause these very intense symptoms. But we also get it from respiratory infections frequently. We'll blow it off. We'll call it normal respiratory flora most of the time, but we're still working with that bug. So all micro lab staff should be offered the meningococcal vaccine, and it should be documented whether that person has received it or whether they refused to get it. So those are the three that I wanted to talk about. Can we eliminate the risk? No. We people who work in micro have to realize that there's always going to be a possibility that we're going to be exposed to these organisms and some other ones. The way to eliminate it would be to say all plate reading, is going to be done inside a biological safety cabinet. Nothing is going to come out of the side of that biological safety cabinet until we know what it is. That's not practical to do. We can't put all those safety cabinets in there and have people work in them. It's just not going to happen. But education of physicians and your laboratory staff, post-exposure monitoring prophylaxis, and whatever policies and procedures need to be done. This comes from the CDC's biosafety manual. The most effective and down to least effective means of mitigating risk of these. One is elimination. We're simply not going to do a test for Ebola, for example. We're not going to do anything. We're not going to do biopsies on a patient that has CGG. You can say that, but it's kind of difficult to do because sometimes we don't know. You know, in all of these cases of tularemia that we had, in all these cases of brucella that we had, we've never had a physician who's told us we suspect this. We've had some people who said we suspected it, but they've turned out not being that. But there was never any warning for any of these that we got. Substitution, do antibodies instead of culture. Okay, change to something that does not need to have much manipulation. Again, often not practical to do. Engineering controls, for us, biological safety cabinets is the key thing there. That's great as long as you can use them all the time. Administrative controls, not surveillance, vaccination, training, and staff education is a big part of it. And believe it or not, the least effective is going to be PPE, especially when dealing with working out with cultures. Okay, that's what I wanted to get through. Really, was just to talk about some cool cases that we've had here. But your lab staff, we're at risk for occupational exposures to infectious agents. And with microbiology, that's going to be those that are particularly more infectious coming off a plate than they are coming out of a patient's respiratory tract or wound or something. We can reduce the risk, but we will never be able to eliminate the risk. It's always going to be there. So you have to have the right laboratory policies to address these, and you have to have the right employee health policies to provide vaccination, post-exposure monitoring, and post-exposure prophylaxis. And I'm very happy to say that both us and our employee health people have been great for this. Like I said, we just finished our 2-week fever watch for several of our employees. We've had serological monitoring going on when we've had brucella. And to my knowledge, we have never had a laboratory-acquired infection caused by one of these organisms. So something to watch for. But something that we'll never be able to get rid of. They're just cool bugs, though. You know, it's one of those bugs that you're kind of like, oh, I want. It's cool to see, you know, but you got to be a little careful. That's it.
So, Dr. Junkins, do you think that if people get that panel that you were talking about with MALDI, it would eliminate having to send specimens to the state?
No, because we're still going to have to follow the same rules that we're not allowed to identify those.
Okay.
That's not our job. Our job is to rule it out. So I'm looking at it saying, at least we'll be able to have it say, I told the MALDI people years ago, I don't care if you don't identify it. Don't tell me it's brucella, but just give me a red flag that says, warning, this might be a select agent. Close it up, keep it in the cabinet, follow your rule out procedures.
Right.
That would be fine with me, but you know, if the first thing we do when we get something on a culture is we MALDI. And if that MALDI tells us this is Francisella, then we can be careful with it. We can still go through the same procedure and send it to the state.
Okay. Interesting. All right. Anybody? I'm sorry.
I've never had a plague. Never had an anthrax. I've never had a Burkholderia, malii, or pseudomalii, although those bugs are now considered to be endemic in the southern United States. It's always been a Southeast Asia thing, or pseudomalii at least, I think. Maybe I'm getting that wrong. But we might see those popping up at some point.
Interesting. They're the epi reviews of these are always very interesting to me. So, does anybody have any questions for Dr. Junkins? All right. Well, thank you as always for presenting, and I hope everyone has a great rest of your day.